Okay, welcome everyone. Can you hear me? We'll start. Okay, we're starting a couple of minutes early because I think most people have got food. This is the third of our thyroid cancer case discussion evenings, and I'd just like to thank RAI again for sponsorship, for webcast, for the food. We have a special guest speaker tonight, a headline act, Professor Bruce Robinson, who's going to speak to us about some of the new stuff that's out there in regard to stage 4 thyroid cancer management. I must apologise to Andrew Parison, whose case is going to be presented straight after Bruce. I thought you were part of Bruce's slides, but you're separate, so apologies that you don't rate a mention on the actual program. I'm sure you'll cope. I like it. And and then there'll be 3 cases after that, and please feel free to graze in between. We'll try and make it continuous presentations with not too much interference with food, but hopefully you'll be able to graze outside and bring your food in as well. So over to you, Bruce.
Okay, so what we're going to talk about very briefly tonight is just show you and remind you of some of the survival data for people with advanced thyroid cancer and the role of radioactive iodine, because of course radioactive iodine remains the best way of treating these people if patients respond to radioactive iodine, and we must never forget that. And I must say I still get sent patients for assessment for TKI therapy, and some of these patients have never been assessed as to whether they might respond to radioactive iodine. One I can remember very well was sent along having had surgery in England for TKI therapy because he had a lung full of metastases. I did a radioactive iodine scan on him. He lit up like a Christmas tree, and 3 doses of radioactive iodine later, he's disease-free with a thyroglobulin, well, not quite disease-free, but a thyroglobulin in the teens. So make sure you always do assess people for their radioactive iodine responsiveness. We'll touch very briefly on tyrosine kinase inhibitors and the fact that many of these inhibit multiple tyrosine kinase molecules. And at the very end, I'll talk to you about one of the new drugs from Loxo, which is a company in North America, who have a very specific tyrosine kinase inhibitor, which is very specific for RET. And it's only suitable for people who've got a mutation or a rearrangement of the RET proto-oncogene. And that's not all, in fact, it's not very many forms of differentiated thyroid cancer. It's many more forms or people with medullary thyroid cancer, but we'll talk about that right at the end. I'll give you a very brief outline of some of the data that has come from the SELECT study, which was the big study looking at the role of lenvatinib in people with poorly differentiated thyroid cancer, and give you some of the updated data that has been published following further analysis of the data from that study. We'll touch briefly on who it's appropriate to treat, when it's appropriate to treat them, and what dose you might want to think about starting people on. And we'll talk also about the management of side effects. So just to remind you of this data that was published back in 2006, showing you that radioactive iodine refractory disease has a very poor 10-year survival of only 10%. And you can see here the difference between these 3 different groups. These are people who have radioactive iodine uptake initially, who attain negative imaging. They have this sort of survival plot. People who do not attain negative imaging, so people who remain I131 positive, have a survival curve that looks like this, and the people who have no radioactive iodine uptake have a survival curve down here. So this is a bad disease if you are unfortunate enough to have radioactive iodine resistant disease. Now, in the SELECT study, because of the nature of the study, the primary endpoint was progression-free survival. And this shows you the difference in the people who were treated with lenvatinib and the people treated with placebo. And this was the headline data that was published by Martin Schlumberger in the New England Journal back in 2015, showing that the median progression-free survival was 18.3 months versus 3.6 months in the placebo-treated group. And that was essentially the data that enabled this drug to get on to be approved by the FDA and subsequently to be approved by the TGA and to go onto the PBS here in Australia. And it's been on the PBS, I think, now for about 2 years, 3 years. Time flies when you're having fun. So that was the primary data. Updated data that was published by Andrew Giannakakis just last year with further follow-up of these people shows that that data has held up and remains very robust, essentially the same sort of progression-free survival. The big question that was asked is, do these drugs actually help you live longer? Was there any overall survival benefit? And this just also, I forgot about this bit, this just shows you that in people who do respond to lenvatinib, the duration of response that's seen has a median of 33 months. So if you're lucky enough to respond to these drugs, you often end up being able to stay on them for a long time and remain free of progression. Now, the overall survival data, unadjusted for the fact that in these crossover studies, it's really difficult to measure overall survival, and this is one of the problems with crossover studies, showed no survival benefit for people on lenvatinib versus placebo. But using this very fancy statistical method, which I always have to look up, RPSFT, which corrects for the fact that nearly 2/3, or was it 80% of people in this study were crossed over from placebo to the active arm, you can actually see when you apply this statistical adjustment, and it sounds like trickery, and I suppose it is a statistical adjustment, so we need to bear that in mind, you do actually see an overall survival benefit for people treated with lenvatinib versus placebo. Now, the other question that's often asked and was specifically looked at in the subsequent analysis from the SELECT study is, does age make a difference to your ability to respond? So in now looking at these two different cohorts, in the firm lines, the people who are aged under 65, again, this line here, lenvatinib treated versus this line here, placebo treated, you see there is a difference. But likewise, in the people aged over 65 years, lenvatinib versus placebo, you see that the same difference in survival applies. So these drugs are able to be used with effectiveness in people who are elderly. And in fact, in the SELECT study, over 40% of the patients in the study were over the age of 65. There was no difference in the baseline characteristics between the older and the younger patients. Progression-free survival did not differ, but the response rate did differ in the elderly people. Wasn't quite as good as it was in the younger people, but nonetheless, in this work that Marsha Brose published in JCO in 2017, the drug could be used quite effectively in elderly patients, and we should not forget that. Again, the overall survival data showing this difference. In fact, it was statistically significant in the elderly patients, but not in the younger group of patients when adjusted as I've described previously. So just to give you a real case, what would you do about these two different sorts of situations? Here is a man who's 79 years old, back in June 2015, had a thyroglobulin of 115, at that stage was symptom-free. He subsequently has a rise in his thyroglobulin in January 2017. He presents with shoulder pain, and on an FDG PET scan, lights up like a Christmas tree with disease here in his chest and in his shoulder where the scapula was painful. So this patient has radiotherapy to his scapula, to his left chest wall, and also to this lesion down here in the femur. And he clearly is the sort of patient who will need treatment and will likely respond to it. So I contrast those two different situations in the same patient. often the best thing you can do with these people is sit and watch. And make sure when you make the decision to move to a tyrosine kinase inhibitor, you do so acknowledging that there are significant side effects associated with these drugs. They can be managed in most cases, but you need to, disclose to the patients that these side effects and their management are not trivial issues. And you don't want to take a person who at this stage was well and turn them into an unwell person. And I think that's a really, it's a good rule to follow in medicine generally. Don't make a well person unwell. Here we've got a man who clearly is unwell, and so trying to do something to help him get better is, I think, a more readily justified thing for us to do as physicians. Now then, one of the other things that we looked at in subsequent analysis from the SELECT study was how quickly do people's metastases change in size. And this showed you that even at 8 weeks, there was a 25% initial reduction overall in the size of metastases. And in fact, when we broke that down, I don't have a slide to show you this, it was the people who had soft tissue metastases, particularly liver and lung metastases, who had the greatest decrease in the size of their tumours. People who had metastatic lesions in bone we didn't see a decrease in the size of those, but that was often because they caused lytic lesions in bone and you just couldn't measure it. They were actually it was quite a good tool for helping relieve bone pain from lytic bone metastases in this study. And you should think about it as a palliative agent in people with bone metastases. I'm not saying don't irradiate those metastases, because I still think that that's an important thing to do, but I think this can be a useful adjunct to the management of specific metastatic disease in certain sites. And the other important point to note here is that there continued to be a very small but continuous decrease in the size of these metastases out to the end of the period of analysis in this study. So it's only small, you don't continue to decrease the size of these things much out here, but nonetheless they continue to respond while they continue to respond. And it's only when these patients develop resistance to these agents that I think you've then got to think about an alternative way of treating them. But while they're responding, try to keep them going. Now, the other important thing to note here is that, and we should talk about from a practical point of view, is that side effect management is a really big issue in these drugs, and it can significantly impact on the quality of life of these people. The side effects, the most common ones are noted here. Hypertension is quite commonly seen. People develop diarrhea. Fatigue is quite a significant problem, as is weight loss, nausea, stomatitis, and this phenomenon known as the hand-foot syndrome, which is depicted on this slide here. People develop these blistering lesions on their hands and on the soles of their feet. This can make it actually really difficult for people to walk. These blisters can become so painful. And so we need to think about how we're going to go about managing these. During the SELECT study, 82% of the patients had periods where the dose was withheld from them. So the treatment was stopped. We were given what we call drug holidays. And I'll talk a bit about how we go about doing that in a moment. 68% of people had dose reductions. Remember, the starting dose in the SELECT study was 24 milligrams, and Eisai is actually planning another study at the moment that is going to look at comparing one starting dose with another. I think it's going to be 18 versus 24 and 18. So that's because so many of the patients, and in fact the mean lenvatinib dose during the SELECT study was only 17 milligrams, raising the question as to whether we were actually starting people in the SELECT study on too high a dose. Having said that, one of the things that we did notice in the SELECT study was that those people who had the best responses were those who had the most side effects. And in fact, the development of hypertension in these people seems to almost be a correlate of response. And so when patients express disappointment that they've developed hypertension and their side effect, I often say to them, don't worry too much about that. It may mean that you're responding. And we need to manage the hypertension. And presumably, if we could go back and get out all of those samples and look at the PK data, presumably we would see that the levels of lenvatinib in the people who developed hypertension were also highest, and that was presumably a factor which was contributing to the good response. Adverse events can be managed by dose holds and dose reductions, and as I've said, 82% of people and 68% of people respectively in the SELECT study had drug holidays or dose reductions. And this shows you here, really importantly, that it was the progression-free survival benefit was compromised when the period of dose reduction exceeded 10% of the total treatment time. So you can actually have fairly lengthy dose interruptions before you significantly have an adverse effect on the patient's outcome. Patients, of course, are terrified to stop the drug. Once you've started them to suggest even that they might be off it for a week, you can see the panic in their eyes. You know, what's going to happen in that week? They feel as though they've been thrown a lifeline. What this shows is that it wasn't until you withheld doses for over 29 days that you saw a significant difference in the progression-free survival responses. So a dose hold of a week or 2 weeks while the patient recovers from the side effects, and it doesn't take that long for them to recover because the half-life of lenvatinib is only 28 hours, so it gets out of the system fairly quickly. Often within a week, patients feel remarkably better. And you can then either reintroduce it at the same dose or reintroduce it at a lower dose in order to continue to derive benefit from the drug for patients. Hypertension was the most common adverse event. It was quite severe in many cases. 47% of them had occurred in the first cycle of treatment. As I've said, it was associated with an overall survival benefit, presumably for the reason of higher drug levels. The best thing to do is to optimise the management of the hypertension rather than stop drug, because patients are often asymptomatic of this hypertension. It's the fatigue and the skin problems that really require drug holidays or dose reductions initially. And these patients' hypertension needs to be managed with usual antihypertensive agents. A2 receptor antagonists, calcium channel blockers, ACE inhibitors. All of these drugs are perfectly fine to use in concert with lenvatinib. A little bit of data suggests that in the study, calcium channel blockers were used more than ACE inhibitors and receptor blockers than diuretics and beta blockers. Now, just to finish up, because I want to leave plenty of time for cases, there are now two new agents, which are very specific in their ability to target RET and to inhibit the RET tyrosine kinase activity. These, of course, are drugs which are most suited to patients with medullary thyroid cancer. But in both of these studies, there are arms that will admit patients who have RET rearrangements. Di's PhD thesis was on RET rearrangements back in the mid-90s, and I think she described a new one. So in 15 years, nearly 20 years, isn't it?
It was the last century.
The last century, that's right. We've come a long way. We realised that there are lots of these RET rearrangements. In fact, I was sent a case from Prince of Wales today of a patient who has a RET rearrangement in an papillary/insular carcinoma that Anthony Gill has just looked at. That patient might be suitable for going into the LOXO 292 study. But the standard poorly differentiated thyroid cancer patient is not, because most of them don't have a RET rearrangement. Now, of course, one of the things we are trying to get set up at North Shore at the moment is the ability to screen all of our patients' tumours, not just their thyroid tumours, but lung cancers, all tumours, for a range of genetic rearrangements, the sort of thing that's pretty much standard of care at big cancer centres in North America now. Sloan Kettering, I think they're now, Anthony, screening what, 400?
Yeah, 470.
470. The number goes up every time you hear. 470 specific mutations in all tumours. We need to be able to do that to make sure we can offer our patients with whatever tumour type they might have the most appropriate therapy. So I just bring this to your attention. Hopefully before too long we will be doing this sort of screening of all of our thyroid cancer patients so that we will identify those patients who will be suitable for very targeted RET therapy as opposed to pan-tyrosine kinase inhibitory therapy, which is what lenvatinib offers. Pan therapy is not necessarily always bad because these tumours often have multiple tyrosine kinases driving their growth. And even some of the medullary patients have multiple tyrosine kinase receptors driving the growth of those tumours. So some of the patients in the LOXO study subsequently do better when you put them onto cabozantinib, for example, which has got a broader spectrum of tyrosine kinase inhibitor activity. But it also has a much broader spectrum of side effects. The good thing about these very specific RET TKIs is very, very narrow side effect profile. Now, I might stop at this point because I'm mindful of the fact they don't want me to speak for no longer than 20 minutes, and it's 20 minutes.
No, that was great, thank you, and we'll get Andrew in a moment.
Andrew can present.
Can I just interject?
Yeah.
So people ask me, when do you as an endocrinologist refer these people sideways to oncology? And as you know, Mike Tuttle routinely hands them over, and he involves the oncologist a year before he thinks they're going to need the oncologist so that together they can follow the trajectory of disease progression. I mean, I think as endos, we're better at predicting how thyroid cancer behaves in the intermediate grade ones and then maybe in the early days of the stage 4 ones. But what do you think about that? Because I think you're one of the few people that actually thinks endos should be managing this rather than oncologists.
Well, but I suppose I think that because I think we can provide continuity of care that a lot of these patients want. Inevitably, we will all be discussing these patients, hopefully in multidisciplinary team meetings, and we'll be involving surgeons and radiation oncologists at very least. I've always regarded the expertise of oncologists as being predominantly with antimitotic agents, right? But I know that that is a narrow view. I think it's always wise to have a good relationship with your oncologist so that when you need help with specific agents that you don't feel comfortable with, they don't feel ready to give you the finger. I think it's... so look, it's horses for courses. I suppose by being involved in these trials, some of us at North Shore have developed a comfort with these agents and their use in this group of patients that I don't think most of the oncologists have. Now, I know in Canberra, one of the oncologists has got a real interest in helping look after these patients, and she may well become the person in Canberra who looks after all of those.
Great, okay, thank you.
Is there any advantage or evidence to a pulsed approach for lenvatinib, week on, week off?
No, there's not, because that hasn't been studied, Andrew. No, it's never been studied. In the SELECT study, people were given it continuously unless they needed a dose interruption. But the aim of the study was not week on, week off, like it was with sunitinib and sorafenib in the early days where they were given 3 weeks, or I think sunitinib was week on, week off. Sorafenib, I think, was 3 weeks on, 1 week off, from memory.
So that segues into another question. People have raised the issue of rebound. So if you stop the dose for a holiday or you reduce the dose, anecdotally there have been cases of aggressive progression, although from your data that would obviously not be the case in overall. Is that
correct,
true?
Correct. Having said that, we've had a couple of people, one man I remember very well, one of Sean McGrath's patients who developed a hernia, had to stop lenvatinib for surgery for I think about 6 weeks, and during that time his disease literally took off and he died. Yeah. So I think whilst you're inhibiting the tyrosine kinase activity, you can keep a bit of a lid on things, but once you take it off, usually the decline is quite rapid. And in some ways, that's quite good because it means the period where palliation is required is quite short. As long as patients understand that, they don't have a long lingering death. In fact, if you stop the agent, you can be pretty confident that it's going to be quite quick.
Okay, great. Any other burning questions? If not, we might... Can I just get some guidance about food? Do you want us to proceed and...
It's up to the
Okay.
I think if there's food out there, maybe we should.
Do you guys want to have a 5-minute break to?
They are
grab a
bringing
bit
the
more
food in here. They're putting the
Okay,
food on the table.
perfect. Okay, so Andrew.
Can I just say as well, anybody who speaks into this roving mic, just there's about 17 people on webcast, and so they can hear if you can be really clear and speak into the mic so they don't miss out. That would be great. Thank you.
No, that's okay. Yeah. Well, thank you, everyone. My name's Andrew Paris, and thank you for asking, but really allowing me to present this case. Basically because I need your help. So Bruce and I are involved, but this is Mr. JP. He's 64 years of age. He's a really nice chap. His background of high cholesterol, sleep apnea, diabetes. He's short and he weighs 100 kilos. His history started about 2 or 3 months ago when he presented with back pain. GP did a few tests and subsequently did an MRI scan that showed a T12 anterior body mass with a pathological fracture. And over the last 2 or 3 months, his pain eased. This man has no family history, no history of radiation exposure, and specifically no local neck symptoms. He had a full body CT scan which showed multiple lung nodules and a left thyroid/isthmus mass. His TSH was slightly suppressed and had been less than 1 since 2009, and his TG that I measured was over 5,000 with a negative thyroglobulin antibody and normal anti-TPO. PTH normal, calcium normal, calcitonin normal, and everything else there normal apart from a slightly low vitamin D. Organised a fine needle biopsy of his thyroid mass, and that was suspicious for neoplasm, can't exclude papillary, follicular or poorly diff, but certainly not medullary. And he went on and had a PET CT scan. Any comments so far? And would you like to see the PET CT yet? Anyone want to go straight to surgery? Any surgeons, Mark? Anyway, my thought was that this was metastatic thyroid cancer, and it would be a good idea to get his thyroid out. So he went to theatre, we made a big cut. He's a really short guy. The thyroid was not palpable in the neck. The operative findings were a large vascular thyroid mass involving the left lobe and isthmus. He was short, and the thyroid basically started at the thoracic inlet and extended into the mediastinum. And basically, my thought was that he had a poorly differentiated or anaplastic carcinoma at the time. He had very ill-defined planes. It was extremely vascular. It was hard to get off the isthmus. I was able to get around the lateral surface and take the jugular off it, but that's as far as I went, and pulled out and did a biopsy, and he has made an excellent recovery. And his pathology has been reviewed with Douglas Hanley and by Anthony as well, but that's a pathology review. But in summary, Anthony thought it was a follicular carcinoma, although not sufficient to fulfil the Turing criteria for insular. There are areas suggesting a tendency towards dedifferentiated, towards insular carcinoma. This was poorly differentiated clinically. And he's also had tissue sent down to St Vincent's for further typing, but it was BRAF negative, ALK negative, RAS negative, calcitonin negative, and diffusely thyroglobulin positive. It was reviewed by Bruce, but I'll just show you the scans first of all. Yeah, I don't know what's happened. What I'll do is I'll just close this presentation. So this was his scan. What do you think? Okay, this is the scan here. So this was his thyroid mass. So as you can see, trachea here, these are his clavicles. So basically the thyroid started at the thoracic inlet, and we have a very large mass. You can't see it clearly here. There is a plane here between the mass and the esophagus, so I thought it was worth trying to get this out. And working our way down, you can see it extending into the mediastinum with tracheal deviation to the right-hand side. Some tracheal narrowing. And down there into the mediastinum. And then to show you the mass. You'll have to trust me, he's got a T12 body mass as well. Oh, sorry, technical failures. So I have sent him to see Bruce. And this is what Bruce thought. So we've sent him for genotyping, started him on lenvatinib with a view to shrinking the tumour, perhaps make it easy to get out. We'll be repeating his scans in 1 month's time to look at the response, but possibly not doing anything for 8 weeks. He has commenced radiotherapy to the spine. There is some risk to the spinal cord, so he's currently having radiotherapy. Once that's all done, then proceeding to thyroidectomy, and then doing a thyrogen-stimulated radioactive iodine scan and or ablate. Does anyone have any comments?
Why we suggested that order of doing things was that the radiation oncologist, and when we looked at this scan, were concerned that if we gave thyrogen, first of all, to assess his radioactive iodine responsiveness, we could have compressed his cord. So, on the other hand, Andrew needs to try to get the rest of the thyroid out, because again, we can't really give radioactive iodine with half his thyroid in there. That's why we chose the order that we did. And the reason we chose to use lenvatinib in this situation is that we have had some success previously in a patient with anaplastic thyroid carcinoma that Mark Sywak and I looked after last year, in whom the tumour was large, and we were able to shrink it sufficiently for Mark to be able to subsequently remove the thyroid, and he lived a year before eventually his lung metastases caused him to succumb. So that was why we chose that order of action. But I've got to say, I did think about it fairly hard before saying, well, this is what I think should happen over what period of time. Anyone have any comments? Anyone
Any comments
disagree?
so far?
Monica?
Yeah, can I ask why you're doing thyrogen stimulated in this patient with metastatic disease and not withdrawing?
That's a good question. The main reason, Monica, is that he's still got, and until he's had his thyroidectomy, we can't really withdraw thyroid.
No, I know, but it was after the
Yes,
thyroidectomy.
that's right. So it's a good question. The main reason is timing, that I can get the results of a thyrogen-stimulated scan very quickly, within a week, you know, Monday, Tuesday, Wednesday, Friday, whereas to withdraw will take me a month. And I don't think this guy's got a month. He's got, you know, as Andrew's described him, he's very short, very squat. His breathing is already, I think, borderline compromised. And I think the sooner we can get the rest of that thyroid out, the better. Because as you can see, it's pushing his trachea.
Oh, yeah, no, I agree. Because you can't give iodine until you get it.
That's right.
But, you know,
So it's really a question as to whether you'd be prepared to wait a month to withdraw it and how he would feel in that month versus the slightly increased risk of edema following thyrogen. That's what you're getting at, right?
And also, I thought there was some data Also, I thought there was some data to suggest that with metastatic disease, the response is better with thyroid hormone withdrawal rather than thyrogen.
I don't think that's the case.
No?
Monica, no.
And it's so much worse for the patients.
Yeah.
Sorry?
I don't think there is any good data.
No.
And it's even
Yeah, I don't think there is any good data. I mean, it has been suggested, but the guidelines have said that it's quite acceptable to use thyrogen for metastatic disease, even though the PDS is another issue, but we won't discuss that.
No.
Let's not spell that out too much, but yeah, thyrogen's a much better way to do it.
Yeah, Anthony. I mean, the PBS is one example where you're better to ask forgiveness, not permission, I think.
I was wondering, Bruce, with the risk of fistulation, how do you judge that with these patients? Like, what approach do you use starting lenvatinib and risk of getting a fistula?
That is a big risk. I don't think there's anything you can do to prevent it, Anthony, but you have to be aware that it's a distinct possibility, because what Anthony is referring to is particularly after surgery, and in this guy, the lenvatinib would have to be stopped for a few days before surgery and at least for a week after the surgery has been done to enable complete wound healing, because these drugs inhibit VEGF and so do inhibit wound healing. They also can contribute to fistula formation. And of course, if he develops a tracheoesophageal fistula, for example, that will be a disaster. But it's a risk I think we have to take. I mean, do you know how you can prevent it other than careful surgical technique?
I suppose carefully selecting the patient. So if you think it's invading into the trachea, perhaps you could take a different approach from lenvatinib, but I'm not really sure.
Yeah.
It also leads me to the next question. If we do get shrinkage and we do go back in this man with metastatic disease, if we needed to do a laryngopharyngectomy to clear the disease, would you do it? Because that's what he may need. I mean, we could get in there and debulk it and shave it off the esophagus, but if I get to the point where I think this needs a laryngopharyngectomy, which he may.
Hopefully by that stage you'll have a sense of how his distant metastatic disease is progressing, and if his distant disease is reasonably well controlled, then you've got that really difficult situation of trying to establish local control. It's a terrible way to die. If he says yes to a pharyngectomy, then I think that would be not an unreasonable thing to do. I think
offer it.
Yeah. I think the most difficult thing for you, though, Andrew, is this guy, on the spectrum of disease, this guy is sitting somewhere between papillary cancer and insular. He's not quite an insular, is that right?
Yes, but I perhaps biopsied the isthmus. I think there was a spectrum of disease from normal in the right lobe through to this disease in the isthmus, and then the right lobe was poorly different. I mean, we could core biopsy the left lobe to be absolutely sure, but I mean, clinically, I think it's absolutely poorly diff.
But he's not going to be one of those. He's not going to be an anaplastic guy he'll be dead in 6 months. So you've got a local control issue on your hands. Yep.
So you would offer it to him. Yep. Okay. Question at the back.
Does external beam radiation have a role for this patient?
External beam for the... I think if it's surgically resectable,
to the neck?
Yes.
So what is not in your list whether to have external beam radiation?
I think thyroidectomy is the most important thing. If we can get it out, that really is the most important. If we can't, I think he won't have much time, and radiotherapy will be palliative. I think it's got to be thyroidectomy, however we do that. And if he wants to accept a laryngopharyngectomy, then it's a big thing to do in someone with metastatic disease. And traditionally, we're taught in surgical oncology that to amputate something in metastatic disease is not the right thing to do, but I think asphyxiation from disease is far worse. So I think it's a palliative thing, radiotherapy.
Well, in our insular cases in recent times, we've used external beam before surgery, and it has been very productive.
Are you talking in a neoadjuvant setting?
External beam radiation to the neck.
Mostly after.
Yeah. Look, we use it mainly...
Some after, some before.
Yeah, I think it's not going to change the operation that I need to do, because if you do need to operate, you should get in 6 to 8 weeks after radiotherapy. And the kill time of radiotherapy can be up to 6 months. And we're certainly not going to wait that long because the adhesions from radiotherapy are horrible. So it will help with margins, but I think a good wide operation will be better for margins than radiotherapy.
This question might be best for Bruce, but just wondering how you select which patients you're doing tumour genotyping on, or are you doing it on all of them, and how you use that information, given that at the moment most have just got lenvatinib available.
Yeah. So, there's a microphone. Well, it's on anyhow. So he's able to switch this one on. So the answer to your question is we are doing this sort of panel. Anthony Gill will do that immunohistochemically, a lot of it. This one, they've got to switch this one on. Yeah, it's on. Yeah, so that's being done immunohistochemically. We're not routinely screening for RAT rearrangements, but that's what we want to be able to do. Why would we do these ones? Well, if he's BRAF positive, then he may be suitable for dabrafenib and trametinib. So I think that's a really important one for us to know the answer to, because there's a drug, and Novartis have been very good, I must say, in providing that for people on compassionate basis. So that's probably the most important thing. ALK, again, would be important to have because there are ALK inhibitors that you can use. Only a small percentage of people will have the ALK positive, but again, if they are, then that enables you to offer another potential targeted therapy as well. Well, this initially was thought to have some papillary elements to it, and you know, when you talk to Anthony about this, he sort of sees a mix of things in it, really. He sees some papilliform elements, some follicular elements, so, and then these tiny little spots where you'd almost call it insular. It's not quite enough, though, to call it the whole thing an insular carcinoma. So, I mean, I think this is a bit of a hybrid beast, this one. The other thing too, other point to make, is that in many of these people, some of their metastatic disease will be I131 sensitive and some won't be. And you pick that up by doing the FDG PET scan. So some of the Mets may respond to I131, whereas others will respond to lenvatinib. And so it's not even out of the question to use both therapies in some of these people.
Yeah, I think that'll be interesting in this guy. I think his lung disease will be radioactive RAI-avid, but it'd be interesting to see what happens with lenvatinib. But I think there's a spectrum of dedifferentiation in this thyroid, and I've probably just picked the middle of the road for the biopsy.
Great.
Okay.
Yeah. Thanks, Andrew. So that's a very challenging case, and so that one, yeah. Yeah. Okay, so I've got a case which is also a mixed, was that your word, Bruce? Mixed beast? Yeah. So this is another mixed beast, but this guy hasn't been genetically profiled yet. So this man is a retired professor of anatomy from a university that's quite close to here, but I won't specify. He's 78 now. When I first met him, it was 2005, and he was 64. And he'd had a long-standing multinodular goiter, and he had a biopsy of the dominant nodule, which is what we did back in 2005, before we had TRADS. And it was a benign category 2 biopsy at the left lower pole. I sent him to Lee Delbridge. Lee's not here, is he? I can use his name in vain now. So I sent him to Lee because I thought it was very bulky and I thought he probably should have an operation. But he was one of those typical patients that hates going to doctors, probably because he's hangs out with too many doctors at the university. But he didn't want to have an operation and he had no symptoms and he had a benign biopsy. So he disappeared and only saw me, I think, twice over the next 10 to 11 years. And then he turned up with a lymph node in his neck. And in 2016, the GP organised another neck ultrasound and a biopsy and sent him to Surgeon B, who's also not in the room. So he had a left inferior nodule biopsy of, it was a 4 centimetre nodule at this point, and it was category 4. And he had a positive cytology in the lymph node that he had presented with clinically. Just to show you, this was the sort of ultrasound. Can you see that, or should I turn the lights off? There's not much to see, but he had one of those typical big, lots of nodules in both lobes, and this was sort of nodule, partly cystic, very benign looking but bulky thyroid. Sorry, it projects pretty poorly. It's much clearer on my computer. Okay, so he had surgery in 2016. He had a total thyroidectomy with a left nodal dissection, and it was a 5.5 centimetre poorly differentiated left thyroid lobe cancer with mixed papillary, follicular, oncocytic and tall cell foci with vascular invasion and 1 out of 47 nodes, PT3 N1B. So yes, definitely a mixed beast. And he had radioactive iodine with 6 gigabecquerels with thyrogen in May 2016, and that was dose 1. And I was very disappointed to see that his stimulated thyroglobulin at the time of radioactive iodine was 319, so that worried me a lot. His radioactive iodine uptake scan post-ablation had only bed uptake, so that didn't really account for the thyroglobulin of 300. And so I thought this is going to be nasty. He, after that, had ongoing imaging of his neck and his chest, which was clear. And for reasons which will become apparent, he ended up having another dose 6 months later. And at that stage, his stimulated thyroglobulin was 3,100. So it had risen by 10-fold in 6 months. And again, he was essentially iodine negative at this point. So the bed had gone and there was nothing else to see, and that always smells bad, like bone metastases. So I'll just show you on the graph, when you plot the stimulated thyroglobulin, it's slightly misleading, and when you plot the unstimulated thyroglobulin, there were fluctuations, but gradually what's happened is a gradual rise, but we're looking at a y-axis that's a little bit misleading. So yeah, first dose of radioactive iodine, second dose, much higher stim TG, and yes, bone mets is always what you worry about. So on the second dose, he had a stim PET, which I'll show you in a moment, and he had bony mets in the sacrum and also the left femur. Again, not really enough metastatic disease to explain a stimulated TG of 3,100. So I was still pretty nervous, even though I knew he had bony mets. It looked like oligometastatic bony disease. He had a small lesion in the femur, which was asymptomatic and didn't need management. He had radiotherapy, spot welding to the sacrum, which was the biggest met. And he had some vague posterior chest wall pain and back pain, which worried me as well. So an MRI of his spine and a CT of an abdo outside the hospital had been clear. But again, I was nervous. And meanwhile, his unstim TG had gone up from about 70 to 416. So he had his second dose, and I always like to do a stim TG at the time of the second dose. So they come in after thyrogen, have a PET scan in the morning, have their stim TG and then their dose of radioactive iodine. And you get that flip-flop effect where you can do the FDG PET assessment and also the post-ablation radioactive iodine assessment. So he had something new on FDG PET this time round. He had bony disease and he had a pancreas metastasis. So I'd never seen a pancreas metastasis from thyroid cancer before, and I was a little bit worried. Meanwhile, Veronica Prida, who's not here, is she here? No. Very kindly presented this man as a poster at the US Endo Society meeting in March last year. So I'll just draw attention to the scan. This is the CT showing the pancreas metastasis. This is the previous PET scan before we knew about it, showing the bony disease. And this is the PET scan, which I'll show in more detail later, showing the pancreas metastasis. And so I did wonder, is this cancer from thyroid or is this a primary pancreas lesion? And the reason we knew it was thyroid was because he had an endoscopic ultrasound with biopsy. So it was a 2.9 centimetre mass in the body, in the tail, with an abnormal lymph node, 2.3 centimetres adjacent, with a splenic vein thrombosis. And this was just before Christmas in 2017. I managed to get one of my oncology connections to organise an endoscopic ultrasound with biopsy, and he had positive TG, PAX8, TTF1, etc., negative BRAF. He had absolutely no clinical problem from this, so he didn't have pancreatitis, he didn't have diabetes, and he didn't have jaundice or anything. It was in the body and the tail. So the question was what to do about a pancreas metastasis. So any ideas what people would do? So is this a time when you give him lenvatinib, maybe? No?
It could be discussed.
Okay. So
Where is it in the pancreas? Could it be
in the body and the tail. No, we looked at the literature, and the literature showed, I think, somewhere between 8 and 30 reports. And yes, a lot of them had been resected, but I'm sorry, I thought that was the wrong thing to do, to have pancreatectomy or partial pancreatectomy for someone who's clearly already got stage 4 disease and who has no symptoms from his pancreas metastasis. And he's the sort of guy that would never have agreed to that anyway. He's got a son who's a doctor down in Canberra, and we discussed that at great length. I decided I'd give him a 3rd dose, even though I knew it was empiric, to see whether it lit up with radioactive iodine, and it didn't. And I called on my oncology colleagues, including Andrew Kneebone, who's a radiation oncologist who's had extensive experience with local radiotherapy for isolated pancreatic metastases for other cancers, and has had quite good results. And I think that's where we do need to liaise with oncology when we're dealing with a situation that's new for us. And I am not a trained stage 4 stage 4 cancer doctor. So he had local radiotherapy to the pancreas metastasis, which was asymptomatic. And this doesn't really tell you very much, except to tell you that he had a 3rd dose. But this does. So down the bottom is the panel of imaging before the radiotherapy, and there it is. And up the top is the panel of imaging after radiotherapy to his pancreas. And it was a almost complete metabolic resolution with no side effects at all. So I think that's a better outcome than having pancreas surgery. Okay, just showing on this panel, the alternate pictures are before and after, before and after. So again, before and after, before and after. And again, down the bottom, before, and you can see the bony metastases here as well, the pancreas metastasis, and then after local radiotherapy. So he's had spot welding to his sacrum and now spot welding to his pancreas with pretty good outcomes. And the guy is asymptomatic.
Is that the liver metastasis?
Wondering whether someone would notice that. There's a nuclear physician in the audience, and Jeremy as well. So yes, I'm coming to that. Yeah, well spotted. So yes, other sites. So down here we're looking at the liver now, and he's got new liver disease. So his pancreas has got better, but he's developed a liver metastasis. Apologies, this is mislabeled, but it's before, after, before, after. And you can see that during that time also the sacral metastasis, which had already responded to radiotherapy, is starting to regrow. So there's kind of mixed disease at various stages of response with this man, all of it pretty much asymptomatic. And again, the bony disease is starting to progress. However, the neck and chest completely clear, so no symptoms in his neck or chest and nothing to find on imaging in that area. So this is progress last year, his unstim TG starting to rise gradually, new liver mets, minor progression of bony mets. We've already treated the sacrum, we've treated the pancreas successfully. What do we do now? What would everyone do now? do nothing because he's perfectly asymptomatic? Or are we worried about the TG rising? So the stim TG we haven't done for a while, but it's actually come down from 3,100, but the unstim TG's gone up to 150.
So, what about radiotherapy or radiofrequency ablation of the liver met?
Yeah, so that's a good point, actually. So again, I asked my radiotherapy colleagues about that. I think they thought that it was pretty small. So I did what we all do in this room. I sent him to see Bruce.
Yep.
It's called dumping. He is a professor of anatomy from Sydney Uni, and I thought that he and Bruce would be a good match. Yeah, so I thought, is it time for lenvatinib, or should we do some more spot welding of the liver? And you'd have to say he's done pretty well with that approach so far. And I thought also he'd be good for a trial because he's the sort of guy that doesn't like coming to see you. So if you put him on a trial, you've got Rhonda, the trial coordinator, ringing him up and nagging him to come back every month and making sure that he actually does attend. Anyway, he was assessed for the dose-finding lenvatinib trial and he failed because he's not bad enough. And as you know, we use lenvatinib for symptomatic progressive thyroid cancer, and it was felt that he wasn't symptomatic or progressive enough. So he basically had CT scans in October which showed that the pancreas is still actually getting better. The liver is sort of stable. So in that time between October and January this year, not much has happened. And I actually haven't seen him. And I believe he's moved to to Canberra to be with his son, his only child. And this is his CT at the time of moving, looking fairly unremarkable in his abdomen. And I would be very surprised if he's actually had any treatment at all, but I may be wrong. So maybe the people in Canberra who are on the web might be able to tell me. So I think the question with this patient is, when do we use lenvatinib and when do we just keep going with local treatment for each new metastasis that crops up? Because he's done pretty well and he's not had to have side effects from systemic therapy.
So we had numerous discussions, this man and I, about not wanting to make a well person unwell. As Di said, he's actually quite well despite all this disease, and I just didn't feel that it was really appropriate to treat him. And again, another rule I think is you don't treat numbers. So even if his thyroglobulin is going up, unless he's really suffering in some way, or we've got some evidence that a rising thyroglobulin can be contained in some way with these agents with a survival benefit or a progression-free survival benefit, I find it hard to justify doing it. So I think the wait and watch approach is probably still appropriate in this fellow. And he's certainly not one to make a decision quickly, is he, Di?
So on that note, just for my own education, because I'm not a stage 4 oncologist either, what was the reason, the rationale for treating the pancreatic lesion? To reduce size, which it is, to prevent future pain, or to change his outcomes? So, yeah, what was the reason that was given?
Well, I got a bit nervous about it. It was
because I'd be nervous about pancreatitis and other things.
So I was nervous about it wasn't in the head of the pancreas, so he wasn't jaundiced and he had no symptoms. But yeah, I got nervous about it, and it was big, and I hadn't seen it on the previous PET, so it had grown fairly quickly. And we know that he had a stim TG of 3,100 on dose 2, and I'm sure some of that came from the pancreas met that we hadn't yet seen that was rapidly growing. And yeah, that was my gut feeling. He had this very unusual chest wall pain and back pain, which I'm sure was the pancreas met brewing that we hadn't seen. And then it was there. Oh, you just missed, Veronica just missed your poster man. Yeah. So, I think he's had quite a good result so far, but yeah, and we always worry about if we don't do something now, is it going to accelerate, get worse, and is it going to be too late then? You know, are we going to miss the boat, as it were, to deal with the disease? But this is the problem, because thyroid cancer grumbles along in some people and then suddenly it takes off in other people, and I was worried it was going to take off.
Also because it's so unusual. Like a
Yeah.
metastatic pancreas is pretty unusual, so
Yeah.
I think that might be aggressive with nasty mutations
Yeah.
in this treatment.
Yeah.
Yeah, so it would be interesting to know exactly what the mutation in the pancreas is. I mean, he had the histopathology, but he hasn't really had a proper gene panel yet.
Do you believe he's metastasising from his metastases?
That's a good point, actually. You're right, because there's nothing in the neck.
Yeah, and I'm thinking if that's the case, I mean, you could biopsy the liver, get some more genotyping done, and then treat that. Simple radiofrequency ablation or radiotherapy, and maybe prevent another one.
And just so you know, Canberra have not seen him, endocrinologist.
All right.
Okay, great. So on that subject, are there any other questions about him? Does anyone want to pause for a minute and grab any more food? Like, if you're feeling embarrassed about eating while I'm talking, I don't mind. Every night when I cook dinner for my children, they eat when I talk. They have their phones switched on through dinner like this. They get their laptops out, they switch the cricket on, they switch the NBA basketball on. I'm completely used to it. And I don't get offended. Adam.
Was there any indication that the lymph node involved near the pancreas was extranodal extension in the ultrasound?
It was just a CT lymph node. I presume it's a malignant node, yes, that's
So
come.
because if it's extranodal, it could have spread.
Yeah, I'm sure there are lots of sites that are potential sites of spread. But yeah, this is where we get into oncology territory. I'm a hormone doctor. And his thyroxine's been beautifully managed and his TSH has been kept under 0.1 the whole time. Okay, so we're going to move on to Canberra has a case, and we presented via Canberra last time, and it worked okay, except they couldn't hear what we were saying, even though we could hear what they're saying. So, so I'm going to present their case. So, so thank you for Canberra, if you can hear me, thank you. And please text me if I've said something wrong in the middle of this presentation. And thank you for Rakesh for putting up this case and sending me the slides, and I've never met this patient. So this is a really interesting patient, a 43-year-old female who's a school teacher. She had a left hemithyroidectomy in 2009 for a very large nodule, and I presume that the indication for surgery was size of the lump and maybe plus or minus an atypical biopsy, but obviously she had reasons to have surgery. And she had what was reported as a Hurtle cell adenoma. And she, I think, was well for the next 9 years until she presented with a left 2 centimetre supraclavicular mass in 2018. And fine needle biopsy suggested an oncocytic neoplasm. The mass was excised and was found to be metastatic oncocytic thyroid carcinoma, Ki67 15%, TTF Pax8 positive. So, interesting case. Can you see that? No. Sorry, can you do the lights again? So she had a, I'm not trying to do it with the mouse, whoops. Just here on the ultrasound, you can see, yeah, there was a mass in the thyroid bed. She still had her right thyroid lobe. Her thyroglobulin was 17, as you'd probably expect with someone who has a residual thyroid lobe, and the lesion was 1.2 centimetres. Further investigations, she had 2 centimetre mass on ultrasound. She also had a 1.2 centimetre mass on ultrasound in the bed, and she had a bony lesion, which is here, 1.7 centimetre mass on CT. which you can see here, and that's the FDG PET lesion there. So she had completion thyroidectomy, and they resected the mass on the left thyroid bed, which was oncocytic follicular thyroid cancer in adipose tissue and skeletal tissue. The right lobe was okay. She then had a local recurrence pretty quickly after this operation, so within 2 months. And this was also oncocytic thyroid cancer. And she also went back and had a lateral neck dissection where no lymph nodes were found to be involved, levels 2 to 5. So she had 3 operations in a fairly short space of time, and then was given radioactive iodine with a stimulated TG of 43, a dose of 6 gigabecquerels. Unstimulated TG had been around 5. So on her scan, it tells you the report up the top, but she's got uptake in the bed and an interesting area in the area of the pituitary gland. So we've had thyroid cancer in the pancreas, and now we seem to have thyroid cancer in the pituitary. This is like an MEN1 talk. So nothing to see in the iliac crest, even though that was seen as a lytic lesion on CT. So, oh, Veronica, I'm glad you've come. I'm terrible at MRI of the pituitary. Anyway, this is the MRI of the pituitary, and it's 2 lesions. As you remember, there was some iodine uptake in that area. So a 9 millimetre lesion posteriorly, a 3 millimetre lesion anteriorly, possibly Rathke's cyst, and there was no interval change. So it didn't really look like cancer as such. Would you agree with that? Yeah, okay. In the interim, she had another operation on her left iliac lesion, which was metastatic oncocytic follicular carcinoma, completely excised and positive for thyroid transcription factors and TG, and was given zoledronic acid. I must say, when I was reading these slides, I wondered why they did that operation, and I assume the reason was that it didn't light up with radioactive iodine, and they wondered what it was. But as we know, Hurtle cell cancers often don't light up with radioactive iodine. So I guess you could argue both ways as to whether that was really necessary or not. So she had further progression of the left supraclavicular fossa. Nothing seen in February 2019. In March 2019, another lump in the left neck. So this thing in the neck was very persistent. She had, at this point, what looked like lymphadenopathy there and positive on biopsy. So she has lymph nodes that are pathological in May this year. So she's very topical and very current, and this is her supraclavicular fossa mass. And this is the summary: a 43-year-old female with Hurtle cell cancer, loco-regional and oligometastatic lesions, left supraclavicular fossa nodal disease, recurrent and slowly progressive, left iliac crest, fully excised, query pituitary, maybe not, seems unlikely, never seen it before, but I'd never seen a pancreas met before either. And her thyroglobulin is not too bad at the moment. So basal thyroglobulin, 7 micrograms, and not much higher after radioactive iodine. That could just be a quirk of the nature of that particular beast and the fact that Hurtle cell cancers behave differently sometimes. So she's had quite a bit of neck surgery already. What should we do about the neck lymph nodes that are currently there? And what should we do about further doses of radioactive iodine? And what should we do about the pituitary? And should she have lenvatinib? And why is her TG so low? So does anyone want to comment on any of those issues? And I'm just going to see if anyone in Canberra wants to make any points.
So the first thing, I think this is a surgical disease. One thing that I saw was a level 2 to 5 neck dissection. They obtained 7 lymph nodes. I don't want to be critical of the surgery, but that seems like a cherry pick.
should see 20, 30, 70, sometimes 100.
Okay, all right. So,
There are still nodes there that need to be removed.
Yep, okay. Mark, do you think this is something you'd just deal with surgically?
No, I agree with Andrew. I think that the probably the first lymph node dissection was probably inadequate, given that there were 7 nodes removed. And I think they left the supraclavicular node at that second procedure too, didn't they? But in short, I think the initial surgery was in the lateral compartment was probably inadequate, and I agree with Andrew that he probably needs a full, complete, repeat neck dissection.
Okay, so the surgeons think that surgery is appropriate. I agree with that. Any other thoughts from the audience? Do you think local radiotherapy after surgery, or it's not really necessary because it's not near the trachea?
I don't think that radiotherapy is a strong indication for radiotherapy in a 43-year-old.
Yep.
We tend to reserve that for the patient over 60 or 70, really, with more aggressive insular cancers.
Okay, and Bruce,
So-
what about the fact she's got stage 4 disease with bony metastases? Sorry. Yeah.
They're asymptomatic, aren't they?
Yeah.
Yeah.
I was going to say that I think she needs to be fully staged, so you want to get a good quality CT, a PET CT before you go back in, but I agree with Mark and Andrew that she probably needs another operation.
Yeah, okay. So we're basically going to do surgical debulking and then symptomatic treatment. Okay.
Can I ask whether the pituitary uptake could be from an adenoma and be a false uptake?
It could, yes. So we see false positives on iodine scans in other situations. I think we've probably all had patients who've got radioactive iodine uptake in sites we didn't expect it to be, don't we? And we go on a bit of a wild goose chase doing anatomical imaging. I've certainly had patients with like one little focus in a bone somewhere that is actually a false positive, and we've used an MRI to rule out bony disease, although in this situation she's got something going on in her pituitary, but it's probably not metastatic thyroid cancer. I don't know, I've never seen metastatic thyroid cancer in the pituitary. Metastatic breast cancer in the pituitary, usually it's in the posterior pituitary, they usually get DI. It's possible, I guess.
We've seen one.
Yeah?
Written her up. It's from
Right.
Boyle.
Right, okay.
And I think the challenge with when to jump in, and this is one of the big questions, when do you actually start to use lenvatinib in people with stage 4 cancer? And I think ultimately at the moment, in the absence of really clear data, it becomes a value judgment. I always feel reluctant treating people with a drug which has got some side effects, albeit manageable in most cases, if they're relatively asymptomatic. On the other hand, she's only 43. And so you really want to give her every possible chance that you can. So I would probably err on the side of introducing a little bit earlier rather than in a really elderly person hanging off would be the approach I would take. Even though the data I showed earlier show that elderly people do respond well. So I'm not saying don't use it in elderly people, but a young person has sort of almost got more to lose by not throwing everything at it that they can than a person who's 80 who's
So
arguably...
have you had much experience with Hurtle cell cancer and TKI
No,
responses?
no,
Yeah.
because there just aren't that many of them that we've
No,
had.
but they're genetically different, aren't they?
They
Mind
are.
you, a multi-kinase inhibitor should still work.
Correct,
Yeah.
correct, yes.
Okay. Is Rory here? No. Okay. Any other questions about the Canberra case? Very interesting.
Very interesting. Thank you,
Yeah.
Canberra.
Thank you, Canberra.
Can I just make one comment also?
Yeah.
With the initial biopsy on the node, one of the things that I think they could have done was a TG washing.
Yeah.
And if that was positive, then assumed it was thyroid and done, instead of removing the node first, then just done a block neck dissection at that stage with removal of the other lobe and the thyroid bed. So just to comment on the value of thyroglobulin washings.
Yeah, I completely
in that case.
agree with you. I think it's a really good thing to do. and it's much more sensitive than cytology, isn't it? Yep. Okay, great. So we're running ahead of time, and we have actually got an extra case that's been added on at the end, so that's a good thing. And I'll proceed now on to the case from Macquarie University Hospital. Divya, would you like to come and present your case? Thank you.
And Di, before Divya starts, you guys, Divya? This is dedicated to Bruce in the spirit of unnecessary procedures. I do read my Medscape alerts. And look, Divya and I only saw this lady a week ago for the first time. She's at least a fourth opinion. I think she's seen Lee in the past. She's seen... what else has she seen at North Shore? She's seen a couple of other people, and she's seen people overseas. And it's really that she's a bit topical, very simple case, won't strain our mentation too much, but I'm interested for feedback from the group on what you're seeing and hearing of this type of scenario.
So my case is, this is a 39-year-old Australian-Korean lady who is a photographer by profession, married with 2 children, has been a lifelong non-smoker. No other significant past medical history, not on any regular medications previously. She went to Korea for a holiday, and her sister and her basically went through a general health checkup. There were no thyroid symptoms or any concerns from a thyroid point of view. The checkup included thyroid function tests and a thyroid ultrasound, which showed a 4 millimeter thyroid lesion on the right side of the isthmus with some cervical lymphadenopathy as well. She then proceeded to have a partial lobectomy in Korea with excision of the 5 lymph nodes. And it was a traditional transcutaneous approach through the neck. She was commenced on thyroxine postoperatively, but only a very small dose. This was the histopathology. We didn't actually get the actual report. There was just some findings that was emailed to her from the hospital in Korea.
Perhaps to explain that she has tried to get her information, but she says that the doctor and hospital have basically refused to give it to her. So we take her at her word.
So essentially a 4 millimeter papillary microcarcinoma, no vascular invasion, infiltrative margins, no extrathyroidal extension, but one of the 5 lymph nodes involved with 1 millimeter focus. Subsequently, she was in Korea for a few weeks, came back to Australia, presented to the surgeon at 6 weeks follow-up visit, and so this is back in Australia. She was noted to have suppressed TSH and a positive TRAb levels, and was diagnosed with grave disease with ophthalmopathy. She did not report any other symptoms of thyrotoxicosis, but retrospectively, she mentions that other people in the family had mentioned about ophthalmopathy for about 6 months prior to the surgery, or for 6 months prior to the initial presentation. She was commenced on carbimazole. During her subsequent follow-up appointment, she was noted to be clinically euthyroid with clinically and biochemically euthyroid with slightly elevated TRAb levels. There had been discussions regarding completion thyroidectomy, but she was not keen to proceed with that, and she just preferred to monitor at that stage. These were the investigations. So 2016 was around the time, I think that was the 6 weeks post-thyroidectomy. And the one on the left, 2019, is the recent recent blood test when we saw her. So on examination, when we saw her, she was clinically euthyroid. There was mild ophthalmopathy and slightly raised TRAb levels. And she had had a recent ultrasound, which showed a nodule in both lobes with parotid lymphadenopathy. but essentially stable appearance of nodules over the 2 years since thyroidectomy. So in summary, this is a 39-year-old lady with Graves' disease and mild ophthalmopathy with coexistent papillary microcarcinoma, and she'd had a lobectomy in the past. So essentially, these were the questions when we saw her, whether she required the surgery in the first place, moving forward, ongoing management in the context of Graves' disease. And the third point was she mentioned that she was considering possibly a non-cutaneous surgical approach for completion thyroidectomy back in Korea, but still kind of in the discussion phase.
And so what I wanted to ask the room was, that I've heard and read that Korea has a lower threshold for investigation of thyroid disease and a very high national rate of thyroidectomy. So I wondered if anyone had experience with that.
They have routine screening of the population with neck ultrasound, so they now have an epidemic of overdiagnosis. And they also have a cultural issue with having a scar on your neck. You're apparently unmarriageable. So there's been a plethora of transaxillary and other approaches. So if you're a young female with a scar,
Okay, I didn't know that.
There's a lot of issues here that we need to discuss, and this is a really good case for coming full circle and getting back from stage 4 to this scenario, because we're going to see a lot more of this, aren't we? So who in the room thinks that you're more likely to get cancer if you've got Graves' disease?
If it's unstimulated and if it's uncontrolled for 20 years.
So you may or may not be aware, and you'll like this, Bruce, the Endocrine Society of Australia has a new rational investigation ordering program where we've been asked to make recommendations on minimising unnecessary test ordering, and one of them is that you do not order an ultrasound in someone with autoimmune thyroid disease. Now, I have to say, being medico-legally minded and working on the North Shore, where I see lots of lawyers as patients, I always order at least one ultrasound on someone with either Hashimoto's or Graves to see what it looks like at baseline. But the recommendation is that we don't keep doing ultrasounds unless we can feel asymmetry or nodules. So hopefully I wouldn't be in a situation where I'd have to diagnose a 4mm cancer. But yeah, it's a difficult area. What do you think? Yeah.
I was concerned, first of all, that this case was dedicated to me. I thought you had to be dead to have something dedicated to you.
Anna, what does it
Di, I'll throw a spanner in the works because I'm presenting a paper tomorrow morning at Journal Club on autoimmune hypothyroidism.
Oh, good.
And it's from Brigham and Women's Hospital, and what they've shown is that if you have autoimmune thyroid disease, and so their patients had TPO antibodies, changes on ultrasound, or FNA positive lymphocytic thyroiditis, there was an increased risk if you had a 1 centimetre nodule of that nodule having thyroid cancer in it. So the cancers weren't any more aggressive, but had an increase. So basically autoimmune thyroid disease is a risk factor for thyroid cancer. And so the postulate is being that chronic inflammation, as they see with hepatitis or ulcerative colitis.
So if you ultrasound someone and they're okay at baseline, how frequently do you re-scan them to get the 4mm cancer before it gets bigger?
And the question is, it's not biologically more aggressive, so do you need to find that cancer?
Di, can I ask the room, if we go back to what we know with this lady, we all agree she probably shouldn't have been screened in the first place, but she was. Do we agree that she shouldn't have had a biopsy in the first place, given apparently there was a 4mm nodule? But
get an adequate diagnosis
Yeah.
4mm.
Okay.
The tumour out.
But she appears to have both lobes of the thyroid. So, Mark, she had a lump, a nodulectomy?
She had a nodulectomy.
They do that elsewhere?
It sounds like she's had a discectomy and a pretracheal nodal section. And you find that this is missing, because that's where the nodule was.
Okay, she texted me as well.
Well, the ultrasound report, she has both lobes. I mean, there's not much to feel. It's just a small...
I think we're seeing a number of these for patients. It's interesting, they're Australians, but they go to Korea and have a scan. They don't seem to be able to have their surgery in Korea, and they come back to us for surgery. And we're being asked to give opinions on nodules that we would never have biopsied in the first place. So I agree, she should never have been biopsied.
And now she's here where she is. So do we agree that the MET, which was 1 or 2 millimetres, is probably of no significance in terms of her outcome, so shouldn't enter discussion? And Bruce, I'm reading, yes, sort of 70 to 90% of patients have them if you...
I think you would monitor her clinically if you're going to do anything, and that's probably it, because I don't think it's likely to have any consequence to her lifespan.
That's what we're telling her. I'm not sure she'll follow our advice, because I think she's decided that she wants to go back to Korea and have removal of the complete gland. And so I wanted to ask, so completely separate to this, one of our surgeons has brought a Thai surgeon over to do robotic transoral thyroidectomy. So I wanted to ask if anyone at their hospitals, any of the surgeons are doing non-cutaneous approaches, because I didn't know, Di, that the information you shared with us, and that makes a lot more sense about why these things are gaining traction. But I just wanted to get opinion from the room about the other approaches, and if anyone is doing them, and if anyone thinks they'll actually take hold here.
I think it's a procedure that takes, well, it's taken that surgeon 4.5 hours to do, 5 hours for a hemithyroid. It's making an already challenging operation a lot more difficult. I think we'll see complications, especially in the learning curve that we were seeing in robotic, which is why they were abandoned. And she already has a scar on her neck. So,
I'm not recommending this.
no, I know, but I'm not sure why she would want it. She already has a scar on her neck, and she'll have adhesions. And the way they raise their flaps is by blunt dissection, and it'll just be too difficult. They'll end up tearing the scar or causing ischemia of the skin. I'm going to wait to see what happens with that, but I don't have time to do them.
Which approach are you using?
Transoral endoscopic, which is what was done last week. I think that's out now. I'm not sure what Mark thinks, but
Professor over our way who wants to start.
I think that's, I don't know what Mark thinks.
I've also read the robotic operations cost around 6,000 to 7,000 US versus
They do.
less than 1,000.
And we need to think about the endoscopic ones. I mean, even if it took 2 or 3 hours for an operation that should take 35 to 40 minutes, how much more anaesthetic time, more anaesthetic for the patient, higher complications related to that. And then should we be doing them in the public hospital? Should we take up all that time when you could get 4 done, instead you're doing 1 or 2? Our waiting lists are already blowing out. The cost benefit is just not there.
Under the tongue.
We've been, so that generally, if you want an approach that's not through a neck incision, there's the robotic transaxillary approach, which involves an 8 centimetre incision in the axilla and then a pretty extensive tunnelling up into the thyroid bed. And then the transoral approach, and we've been watching it for the last couple of years. Ankun Anawong, who's the surgeon that Naveen's invited, he's actually a technically very gifted surgeon. The problem is that all of the surgery is done with a hot instrument, so there's no question that the complication rate has to be higher, and particularly in that learning curve, as Andrew said. So, I mean, it's difficult to recommend it to a patient when you wouldn't want it done on yourself.
So how much do you need to do to get up to speed on those?
Well, I think they're saying 30. Yeah.
I can assure you, as we're doing the MBS review, we are absolutely resolute that there will not be rebates for any novel approaches to doing traditional operations. So whether a surgeon does an appendicectomy open or laparoscopically, we have decided that we should not be incentivising in any financial way an approach without there being evidence of its efficacy or benefit over the standard approach.
Bruce, look, I agree, and this lady just illustrates, and others may be seeing, particularly patients with Thai connections, Korean. I'm not sure if other countries are also, also looking at these procedures. But
yeah, and it's a great thing to bring up, and we're actually meeting, as you know, our annual Endocrine Society's scientific meeting this year is in conjunction with AOTA. So we've got a whole contingent of Japanese, Koreans, and Chinese coming. And they're very enthusiastic and they're very productive in abstract writing. So
You're playing off robots.
So thank you, that was great.
Very good case.
Thank you, and a good case to highlight low-risk thyroid cancer. So we have one more case, which is not on the program, and this is a slight segue sideways from thyroid cancer, although the patient does have thyroid cancer. So I'll let Linda come and present this case. Linda Wu's our advanced trainee at North Shore, and I'll let you introduce the case. Oh, sorry, yeah.
Bruce, sorry, Bruce. Bruce, can I ask you a question while we're loading? Should Medicare allow surgery that takes 3 times longer?
Well,
You may not pay.
very controversial
extra,
question.
but should they?
So one of the things that we have considered but have not yet decided to recommend, and probably won't recommend, is to time tier the whole schedule. Because one of the things that's come up during the course of this review is every discipline group comes along with their favourite operation or consultation and says this is undervalued compared to what he's doing or she's doing, and they want it relatively revalued. And we can't do a relative value study. Every attempt to do that has failed miserably because you simply get factions at war with one another. I'm in the middle of a bit of a skirmish at the moment with one of the factions. The idea that's been put forward and discussed, and I'd be interested in people's views, is that we know how long the average surgeon takes to do a certain procedure. The private hospitals collect this data. They know exactly how often to schedule, Mark Sywak doing thyroidectomies or Charlie Chan doing cataracts or whatever. And so arguably we know what the average time is, and we could put together a schedule that simply time tiered all operations. We could assume that most surgeons and most physicians are equal, they're all specialists. We wouldn't actually pay for the time taken because you don't want to reward slowness. If a person has an operation that's in the tier that's between 2 and 3 hours and they can do it in 1 hour and 3/4 because they're very good at it, like you guys, well then you benefit. If you're new and you're starting off and you take 3.5 hours, well then the government doesn't pay any extra for that. Now, this is an idea that gets traction in some areas but doesn't get traction in others. We've been talking about, there's a consultation report out at the moment about time tiering consultations because a lot of surgeons feel that their consultations are undervalued compared to physician consultations, and argue that really the time taken for the consultation should be roughly used as the proxy for the value of the consultation. Surgeons have said to me, if I take an hour to talk someone out of a prostatectomy and I get a rebate of $70 for doing that, it's not a big incentive to talk them out of doing a prostatectomy. It's a big incentive to talk them into having a prostatectomy where I earn how many thousands of dollars. So this is really complicated. I'd be interested in people's views.
Perhaps for another time, Bruce.
Well, I was asked a question. I wouldn't have raised it otherwise.
So just before we go on, sorry, Linda, we keep procrastinating. Okay. Canberra wants to just ask the question about their case. When should the surgery be done? Now? The reoperation in the neck? Soon? Yep. And radioactive iodine after that? Yes.
Depends on histology, what they find.
Yes, okay.
Because patients already had radioactive iodine, and often lymph nodes don't take up the radioiodine. I mean, if there's extranodal extension,
I personally think an empiric dose of radioactive iodine, even in this situation with Hertel cell that doesn't take it up well, is worthwhile. And the literature shows that 60% of people actually have a drop in their thyroglobulin after radioactive iodine that looks like it wasn't going to be taken up. So, yeah. So it's neck operation soon and then radioactive iodine. Thank you.
Di, can I just make one comment about the papillary cancer in Graves' disease? My understanding, there was a higher incidence. And also Susan Mandel presented a paper similar to what Anna was saying in one of the thyroid meetings I attended, that the incidence of papillary and Hashimoto's is higher, but the aggressiveness it's not aggressive. Yeah. And any patient referred to me for radioactive iodine, I will do an ultrasound to make sure that there's not any significant nodular disease, because I'm not going to give radioactive iodine if there's a papillary cancer in there.
Yes, absolutely. Yeah. And I think as a perfect segue into hyperparathyroidism, every time I get someone with hyperparathyroidism, I obviously want to know what the thyroid looks like before they have neck surgery. So on that note... Yeah.
I honestly think that in terms of the ultrasound, you were speaking about the ultrasound as a special test you've got to send someone away for, but I think we've reached the point where young surgeons, endocrinologists should just be so familiar with ultrasound. It's just like a stethoscope. It should be in their office and they should be using it, so it's not a big deal. I'm not sure if that doesn't necessarily have to cost you, Bruce, on the Medicare, but
I think personally.
I think we should be using it very liberally.
All right. Okay.
Again, the review's saying that if there's a report on an ultrasound, then yes, people can be paid for it, but if there's no report and it's part of your examination, then it's part of your examination, just like a stethoscope is. And I think that's a reasonable approach too.
Okay. I might get started then. So thank you, Di, for allowing us to tack on to the end with a little bit of subterfuge, because although thyroid cancer does feature in this case, it's definitely not the main topic, as you can probably tell from this title. It's about a lady who's our current inpatient at North Shore Hospital, being looked after by Dr. Singh, who's I think teleconferencing in, as well as Dr. Saiwak's been involved too. And we just appreciate some second opinions whilst we've got a room full of bright minds. So the case is a lady, Mrs. SS. She's a 33-year-old lady who initially presented to her private endo at 8 weeks gestation. This is her first pregnancy, and she was found to have a mildly raised calcium of 2.66, and at that time on that assay had a raised parathyroid hormone as well of 8. Her background history included that of renal calculi, and she had calcium oxalate crystals. She also had previously had a cholecystectomy, but was otherwise quite well, no regular medications, was of Cambodian origin, but had no family history of any calcium, thyroid, or other endocrine disorders. She did have a 24-hour urine calcium done at this time, which showed an inappropriately raised calcium excretion, and she had a neck ultrasound which found no parathyroid adenoma. In this period, in the first trimester, she had a few admissions for hypercalcemia, mostly in the range between 2.7 to 2.8, and this resolved with IV fluids. She then moved to our catchment area and was transferred to our specialist obstetric clinic, and when we saw her on the 22nd week, her calcium had come up to 2.9. So she was admitted to hospital, and she had some further investigations done. Her parathyroid hormone was raised on our assay, the upper limit normal being 68 at 100, and she had a mildly low vitamin D. TSH was mildly suppressed with a normal T4, negative TRAbs, calcitonin, mednephrines, and norepinephrines were all negative. And she had a repeat neck ultrasound because we were hoping that something would pop up, but there was no sonographic evidence of a parathyroid adenoma either. She did, however, have evidence of multiple right-sided thyroid nodules, which had suspicious features, the largest being 20 millimetres in size. She had a biopsy of that nodule, which came back as Bethesda Category 4. The decision was made that in the combination of this amount of information to go ahead with the neck exploration, to look for a parathyroid adenoma as we had convincing biochemical evidence of it, as well as do a right hemithyroidectomy, and this was done at 24 weeks. During the operation, all 4 glands were visualised, and the right thyroid histopathology was consistent with a follicular carcinoma, which was encapsulated angioinvasive at 23. She also incidentally had a papillary microcarcinoma, a follicular adenoma, and a Hurley cell adenoma. The 2 parathyroids that were removed were found to be fat replete, one measuring 40 milligrams and the other one with some other tissue attached was 230. And her calcium came down significantly after the operation to 2.64 with the normalised parathyroid hormone of 66. Unfortunately, the next week when she was seen in clinic, her calcium had come back up again, within 1 week back up to 2.96, and her parathyroid hormone again raised at 85. She had a repeat 24-hour urine calcium, which was again raised, and was referred again for admission with IV fluids. And at this stage, after around a week of IV fluids, the calcium has plateaued at 2.8. There was a multidisciplinary discussion. The decision was made that given no evidence of a neck parathyroid adenoma, to look with a low-dose sestamib for a mediastinal lesion. So this was her sestamib scan, and it's a bit difficult to appreciate, partly because of the low dose, but if you guys can see, there's a small increased uptake here. which was just adjacent to the trachea on a matched low-dose CT, which was consistent with a T4 level posterior mediastinal parathyroid adenoma. So given the location, cardiothoracic surgeons are now involved, and they say that their recommendation would be for a hemithoracotomy in order to gain access to this lesion for surgery. So understandably, this makes us all a bit anxious, being that she's in second trimester. So in summary, the second trimester window is finishing up around the end of this week. She's got primary hyperparathyroidism with a posterior mediastinal parathyroid adenoma. She's had pretty refractory hypercalcemia requiring multiple hospital admissions. She's also got multiple thyroid cancers, but this is clearly not the acute priority at this stage. And the question to the audience would be, how should her hypercalcemia be managed? So should we pursue medical therapy until term with IV fluids, furosemide, and even there have been case reports of cinacalcet use? The pros would be we could avoid a risky cardiothoracic surgery. The cons would be we potentially may find ourselves forced to pursue surgery at a later stage in pregnancy. And there are risks associated with hypercalcemia, such as preeclampsia and increased risk of stillbirth. And there are risks associated with cinacalcet as well, reported in the literature. The other option would be to pursue surgery now whilst we're in the second trimester window, but there is a risk with thoracotomy. The pro would be we could potentially control the calcium right now, avoid any risks of cinacalcet, and potentially avoid risks associated with prolonged hypercalcemia. And the cons would be the risks associated with doing a thoracotomy in a pregnant patient, which again, there have been case reports of, but not with parathyroid adenoma. So I'll pose the question to the audience.
Rory's just arrived.
Before we ask Rory, why don't we ask Mark?
Well, I mean, I'll let the endocrinologist make the decision on how urgent it is that the hypercalcemia is dealt with. But I'll give you some surgical tidbits. You know, we see mediastinal adenomas rarely, and we were just really unlucky in this case. And I guess the first question, was it reasonable to go ahead with a parathyroid surgery in a pregnant patient without any imaging? Anthony? We thought it was reasonable, and it usually gets you across the line. The second important thing to say is that this mediastinal adenoma is not in an easy location. It's way posterior in the mediastinum. It can't be done thoracoscopically, and it'll need almost certainly a stenotomy, partial, possibly a full stenotomy, and that's a pretty rare thing to have to do in pregnancy. But that's an important technical point for the endocrinologist to understand that this is not an easy location.
Marcos, maybe put it that maybe it's not a parathyroid adenoma. It's in a very unusual location. Usually in the mediastinum, you'll find them in the thyrothomic ligament going down, and that could be something else. And you might do a thoracotomy and find it's a lymph node with sarcoidosis or something in it. Yeah. So you could do, and it's still possible you have a fifth parathyroid adenoma in the left thyroid lobe. So venous sampling may help, but if you were going to do it, I mean, I work at the women's hospital and the kids' hospital, and the obstetricians are happy for me to operate in the second trimester. They say, look, don't treat my patients any differently. We know the evidence is there that you can wait, but do it in the second trimester. But if you can get it closer to 30 or above, if you had to deliver the baby, it would, I mean, even now, the baby would survive.
And the obstetricians are actually quite comfortable with her having surgery, even a stenotomy. She had an MRI scan today that confirms the location of this lesion, and it looks like a parathyroid adenoma on the MRI scan. Okay. Maybe Jeremy can comment on how likely that is to be a false positive on the MEBI.
I think it's fairly specific. I can't think of anything else. I think Andrew raised about nodes. I guess potentially could be. It's very close to the left lower paratracheal station, but there wasn't any other uptake anywhere else.
Yeah, no, this is actually in that. This is a pretty classic area. It's in the aorta pulmonary window. Oh, okay. Yeah, so it's a pretty well recognised spot for a parathyroid adenoma.
I thought it was posterior there along sampling if you still needed more information.
On the flip side, what are the risks if you do nothing? I mean, I've looked after a woman who had hyperparathyroidism to this extent. We hydrated her. She actually didn't get preeclampsia. She delivered a healthy baby. The baby transiently had some hypocalcemia, which wasn't of any great consequence. And she had her surgery after her baby was born. And she turned out to have a parathyroid carcinoma, as it turned out. But we held off because she presented to us at 28 weeks, and we tried hydrating. By then she's kind of 31 weeks and looked refractory, but she had calcium sitting around 3 to 3.1, 3.2 right up until delivery, and she delivered fine. So I'm just worried about the morbidity you might create by trying to do it while you've got a baby in utero, when potentially she could wait.
So I think the right answer will be immediately recognisable with hindsight. So, I mean, the answer is there's no right answer. Jane correctly says we've all looked after patients with hypercalcemia who did really well. I've certainly looked after a woman whose baby died in utero. So, and the risk of death in utero is substantial with a calcium of 3. I think if you did nothing, you'd keep her in hospital. And so doing nothing is not doing nothing. It's keeping her in hospital for the next 12 weeks on intravenous fluids with calcium 3 times a week, and with the obstetricians doing, CTGs every other day. So it's pretty intensive doing nothing. I'm sympathetic to that approach. I think the risk of this sternotomy is going to be substantial, and like everything, I think you put it to the patient and say, what do you want to do? But I think doing nothing is her being in hospital for the next 12 weeks.
Can we quantify the risk of miscarriage?
It's not the risk of miscarriage, there's a risk of death in utero.
So, mate, to answer that, we had one at the PM that we did operate on. I was surprised. They were quoting up to 50% risk of in utero death. Now, maybe that's old data, but I was actually surprised.
It's related to how high the calcium is. And Jane, your lady at 28 weeks had a calcium of 3. This lady's calcium will continue to go up because she's got placental 1-alpha hydroxylase driving very high 125D levels. Normally in pregnancy, PTH is suppressed. So here you've got parathyroid autonomy added on top of what is normal placental calcium homeostasis. So the calcium will go up in the next 12 weeks doing nothing. And that, as I say, I think the risk of death in utero is substantial.
So what about cinacalcet?
So I guess the issue of cinacalcet is that it's a calcimimetic, so we don't, it'll make the numbers look pretty, but whether it is actually triggering the calcium sensing receptor in a manner that's physiologically abnormal for the baby, I don't know. I think if I was doing anything, I'd put her onto fluids and maybe some furosemide and some calcitonin.
Speaking as a surgeon, I don't have the risk of sternotomy at that high. I don't think sternotomy is that big a deal.
Except the surgeon who was supposed to be doing it is not keen.
No, I think you wanted to get a sense of what the risk of not doing it was.
Okay.
Yeah.
Right.
And it could be done, and David felt that it could probably be done as a hemisternotomy, which I think reduces the surgical risks.
So they basically just split the manubrium.
Yeah.
That's what they mean by hemistenotomy, is it? Just split the manubrium?
Split, yeah. Go halfway down the sternum.
Right.
Yeah.
Half a zip, but not a full zip.
Yeah.
How many wires? 3, not 6.
3. Yeah.
True with those zippers, they never join up together. Just as well she's not Korean.
Okay, any other questions?
Oh, that's my God.
All right. Thanks, everyone.
So it looks like we're going to finish early. You'll be relieved of this. It's almost your bedtime.
It is.
Thank you, everyone, for coming. Thank you, ASI, again, for supporting the meeting and providing dinner and the webcast. Thank you to the webcast guys. And hopefully we might have another meeting in November. So, thank you.